Hi everybody, Dr. Chitra here, your mentor at StudyMEDIC and StudyMRCOG, and I am back again with another video for our RRR series for all of you, those who are appearing for January 2025 MRCOG Part 1 exam. So here is a brief summary of what module to expect in which paper, and microbiology and immunology would appear in your paper 2. Immunology is not a very big module, maybe about 2 to 3 questions from immunology. Microbiology is a big module. So what I thought is I'll combine microbiology and immunology together, and today we would be discussing questions from both of these modules. All right. So because it is microbiology and immunology, you are expected to know everything about all the organisms. Frequently asked question is, which is the most common organism causing bacterial vaginosis or implicated in bacterial vaginosis? So the choices are Trichomonas vaginalis, Candida albicans, Mycoplasma hominis, Gardnerella vaginalis, or Ureaplasma. Now, though we actually know that bacterial vaginosis, it is not exactly an infectious disease. The organism that is implicated is Gardnerella vaginalis. Bacterial vaginosis, actually it is a polymicrobial infection, and it is caused by overgrowth of anaerobic organisms in the vagina, and it is one of the most common causes of vaginal discharge. So here, though other bacteria are also implicated, like bacteroids, Peptostreptococcus, Fusobacterium, Mycoplasma hominis, Mobilingus, and Villionella, the commonest organism that is implicated is Gardnerella vaginalis. And what happens is there is like destruction of the normal vaginal flora, and that is why you have all these pathologic organisms that are growing here. And because of this, because the lactobacillus are destroyed, the pH of the vagina increases, and in bacterial vaginosis it is normally more than 4.5. Other things that you have to remember about bacterial vaginosis is the type of discharge. So it is usually a grayish or a whitish discharge with a fishy smell. Okay, and it is not sexually transmitted. Remember, bacterial vaginosis is not sexually transmitted. The treatment of choice is metronidazole. You can either give orally or it can be given locally in the form of a gel. Important thing to remember is that anybody who is consuming alcohol, you have to tell them to avoid alcohol, as you can have disulfiram like effect. Okay. The other treatment, like if metronidazole is contraindicated for any reason, then you can offer intravaginal clindamycin. That has also shown to give good results. Something from immunology. So you have to know what is the structure of immunoglobulins. So we know there are 5 classes: A, D, E, G, and M. Out of this, which one is a dimer? We know they are monomers or dimers or pentamers. Now you have to remember that a pentamer, it is the one that is the most heaviest. So IgM, we know that is the most heaviest of immunoglobulins, and IgM is a pentamer. Whereas IgA, this is the one which is a dimer, and IgG, which is the immunoglobulin with the lowest molecular weight, because it can pass through the placenta, so that is a monomer. And the others like IgA, IgE, and IgD, the dimer is IgA, whereas IgE and IgD, both of them are monomers. So to sum it up in short, monomers are IgG, IgE, and IgD. Dimer is IgA and pentamer is IgM. So you can just stop the video at this point of time and have a look at all the important points of the other immunoglobulins as well. Something about vaccinations. Most of us are practicing obstetricians, and always there would be a lady coming to us and she wants to know what are the vaccines that are safe for her in pregnancy. Now we know. So you have this lady who's pregnant and she has been advised to take the influenza vaccine, but she's scared because everyone knows that giving vaccines in pregnancy is not safe. So she wants to know what type of influenza vaccine are you going to offer her. So the choices are, you have live attenuated, it could be a subunit, inactivated, toxoid or a recombinant vector vaccine. Influenza vaccines, as we know, they are of two types. One is live attenuated and one you have the inactivated vaccine. So remember, this is a pregnant lady. So in pregnancy, we do not offer any live attenuated vaccines. Okay, and also influenza vaccine, it is not a toxoid, nor is it is subunit vaccine. So the one that we are offering in pregnancy, it is an inactivated vaccine. You have to know about other types of vaccines also. So live attenuated vaccines is the vaccine for tuberculosis. Oral polio vaccine is another one which is live attenuated. Measles, rotavirus and yellow fever. Now all these live attenuated vaccines, they are contraindicated in pregnancy. Inactivated or killed antigen vaccines. So you have the whole cell pertussis and you have inactivated poliovirus vaccines. So inactivated or killed ones, they are safe in pregnancy. Then subunit vaccines. So you have acellular pertussis, then you have Haemophilus influenzae or type B HIV, then you have pneumococcal and you have hepatitis B. Now even the subunit vaccines, usually they are not safe in pregnancy, but in some exceptional circumstances, like the woman, she really has to travel to some area where Haemophilus influenzae is very rampant, so you can give her the vaccine at that time. Or any woman who needs recurrent blood transfusions in pregnancy, but she has not been vaccinated against hepatitis B. So instead of exposing her to the hepatitis B vaccine, you can offer her the hepatitis B vaccine in pregnancy. Now toxoids are inactivated toxins. So tetanus, diphtheria. These are the two ones which we know, which we are routinely giving to all patients. So, and they have been time tested and they are really safe in pregnancy. The other ones, mRNA vaccines, these are the ones still under research and some of them have safely been used, but we usually do not offer them during pregnancy. Another typical question would be like, you have the 17-year-old girl who's coming to the gum clinic. She has presented with anogenital warts. And anogenital warts, they could be associated with HPV virus. So the FY1 who is there with you, she wants to know which of these are associated with anogenital warts. So HPV 6 or 11, HPV 16, 18, 31, 33, 33, 35 or 16, 35. We know HPV vaccine, the HPV virus is the one that is implicated for carcinoma of the cervix, but not all are implicated. So you have to know which are the high risk ones that are implicated for carcinoma of the cervix and which are the ones that are implicated in anogenital warts. So 6 or 11, these are the ones that are implicated in anogenital warts, and the other ones, that is 16, 18, 31 and 33, these are usually associated with cancer of the cervix. Okay. A 35-year-old woman presented with vulval itching, non-offensive vaginal discharge. So the GP obtained a consent from her. He took a drop and he put it, a drop of the discharge, he put it under the microscope, and under the microscope he saw that there were numerous spores and hyphae. Now he knew immediately what is the source of this vaginal discharge. So is it trichomonas? Is it chlamydia trachomatis? Is it Neisseria, candidiasis or treponema infection? Obviously one of them is the correct choice. So whenever you know that there are spores and hyphae, it is always characteristic only of candidiasis. No other organism will show you spores or hyphae. Of course, trichomoniasis, you can see it under the light microscope, but that would appear as very motile organisms which are moving very motile across the slide. And the other ones, like the ones causing Neisseria or Chlamydia trachomatis, these are not seen by simple microscopy, okay, under the microscope. HIV ramp is an epidemic that has been rampant, so you need to know everything about HIV. We know it is caused by an RNA retrovirus. Now, whenever this retrovirus it infects our body, so it has to attach to some of the lymphocytes after gaining entry into the human body, so that then the virus can replicate. So which are the lymphocytes that can be invaded by the HIV virus? CD4, CD8, T helper cells, B cells or natural killer cells. We know that whenever we are like following up a patient with HIV, we are always monitoring the CD4 count, because if this virus it enters into the CD4 cells, the cells get destroyed. So anyone who has a very low CD4 count, we know that their immunity is very less. So here it is like whenever to gain entry into a human cell, the viral outer membrane protein, that is GP120, it binds to the CD4 receptors that are present on the T helper lymphocytes, macrophages, dendritic cells and microglia. So here the answer is specifically it binds to CD4 cells. Now, Streptococcus agalactica, it can cause early onset neonatal sepsis in preterm neonates. To come to a diagnosis of this, what is done normally? You will do a culture and sensitivity. Now, these Streptococcus, they show a very specific type of hemolysis on blood agar gel. So, what is the type of hemolysis? Is it alpha, beta, delta, non-alpha, non-beta, or it doesn't show any type of hemolysis? Remember this Streptococcus agalactica, it causes beta hemolysis. Now, how do you differentiate between the different types of hemolysis? See here in this picture, you have beta hemolysis, which is a complete hemolysis. Alpha is a partial one, and then gamma hemolysis, or like in gamma, there is no hemolysis. If you see here, the entire blood agar gel has been completely lysed. So that is why this is a complete hemolysis. In alpha, it is not completely lysed, like you can still get some greenish streaks there. And in gamma, there is no hemolysis at all. Okay, so these are the three types of hemolysis that are seen. And other things to remember about this Streptococcus agalactica, it is Lancefield group B. It is normally a commensal in the lower genital tract. Okay, but it can affect the newborn, and it is one of the most common causes of having symptoms such as bacteremia, meningitis or pneumonia in the newborn, and especially it is the preterm infants that are more commonly affected. Okay, a 16-year-old girl presented with purulent discharge from the cervix. She gives history that she has multiple sexual partners. She is not using any barrier contraceptive. So a swab was taken from the discharge and it was sent for culture sensitivity and also for gram staining in order to know what is the type of bacteria. So the working diagnosis was Neisseria gonorrhoeae. Now, how do these Neisseria gonorrhoeae appear on gram staining? Are they gram positive intracellular diplococci, or are they gram negative intracellular diplococci? Are they gram positive extracellular diplococci, or are they gram negative extracellular diplococci, or are they gram negative cocci only? Remember, this is something that has to come to your mind immediately. Neisseria gonorrhoeae, they are gram negative intracellular diplococci. You don't have to even think once or twice. Okay, the appearance is very typical. They are always intracellular, they are gram negative and they are diplococci. The appearance is like they are a little bit of kidney shaped. Okay, so and always whenever you see anything that is intracellular and it is gram negative and diplococci, it is Neisseria gonorrhoeae and nothing else. Okay, something about immunology. So, which one of the following circulatory blood cell is capable of differentiation into a plasma cell? So, basophil, neutrophil, B lymphocyte, monocyte, or T lymphocyte. Plasma cell is the one that will give rise to immunoglobulins or antibodies. So, remember, immunoglobulins or antibodies, they always develop from B lymphocyte. So, it is the activated B lymphocyte that is capable of differentiating into a plasma cell, and then this plasma cell, it will make large amounts of a specific antibody. Alright. You have a 25-year-old primie. She delivered after a difficult labor. She had massive postpartum hemorrhage. She was transfused with RBCs, to overcome the blood loss. When she was being given the blood transfusion, suddenly she developed rash. She had hypotension, and it very likely looked that she is having a reaction to the blood transfusion. So the blood transfusion was stopped. Now the question is, what was the cause of this reaction? So obviously it was a hypersensitivity reaction. So what is the type? Is it type 1, type 2, type 3, type 4 or type 5? Now unless you know the types of hypersensitivity reactions, you will not be able to answer this question. So how do you remember easily? There is a mnemonic for this which is called as acid. So remember A or type 1, it is because of allergy. So whenever any hypersensitivity reaction develops immediately, so either it is bee sting or latex or due to certain medications like penicillin. So it is because of allergy. It develops immediately, or it is type 1 and it is mediated through IgE. The second word in acid is C. So type 2 or C, it is because of cytotoxic, or it could be antibody mediated. So which are the ones here? Hemolytic reaction, Goodpasture syndrome and hyperacute graft rejection. Now blood transfusion reaction, we know the woman or anybody who is having a blood transfusion reaction, the reaction is there because there are some antibodies that are already there in the serum of this patient, and they attack the antigens that are present on the cells which we are transfusing. Okay, so it is a type 2 reaction and it is because of antibody mediated, so it is cytotoxic. Now type 3 is because of immune complex deposition. Okay, it could be IgM or IgG mediated. And which are these type of reactions? So hypersensitivity pneumonitis or systemic lupus erythematosus, polyarthritis nodosa or serum sickness. All of these are type 3 because here you have deposition of immune complexes. The last alphabet is D. So type 4 reactions are delayed or cell mediated. Now when you have chronic graft rejection or the PPD test, especially for tuberculosis or latex allergy, sometimes could be delayed also, nickel allergy or poison ivy. So all of these are type 4 reactions. So now here remember that anybody who is showing reaction to a blood transfusion, it is type 2 hypersensitivity reaction. Sometimes you can get direct one-liners. So Donovan bodies are associated with which condition? So is it lymphogranuloma venereum, granuloma inguinal, congenital syphilis, herpes genitalis or chancroid? Syphilis ruled out, like congenital syphilis ruled out because we know it is caused by treponema. Syphilis and treponema doesn't show Donovan bodies. Herpes also, no Donovan bodies are seen. So in lymphogranuloma venereum, inclusion bodies are seen, but they are not Donovan. So the confusion usually could be between chancroid or granuloma inguinal. So the answer is granuloma inguinal because Donovan bodies These are basically the rod shaped oval organisms that you will see in the cell. Okay, so these are seen in the cytoplasm of mononuclear phagocytes or histiocytes in tissue samples of patients with granuloma inguinal. Okay, a very hot favorite question of the college. It appears in almost each and every paper, so you have to know this question. Okay, you have this 34-year-old woman. She was working somewhere outside UK. She came back to the UK and she's delighted to find that she's pregnant, so she goes for her booking investigations. When she does her booking investigations, we know that in UK syphilis is routinely tested for. So her VDRL test is reactive. Her Treponema pallidum particle agglutination test is negative, is non-reactive, and also the fluorescent treponemal antibody absorption test, that is also non-reactive. Now she is confused whether she has syphilis or she doesn't have syphilis. So what could be your interpretation of these tests? Is it consistent with treponemal infection at some time? Is it diagnostic of latent syphilis? Is it indicative of early syphilis? Is it a likely biological false positive test? Or does it suggest a past treated infection? Okay. Now here you have to remember which of the tests are, you have a lot of tests for syphilis. So you have to remember which of the tests are specific for syphilis and which are the ones that are non-specific. Okay. So here the answer is basically it is a biologically false positive test. So what is a biologically false positive test? Means a test that is positive to reagent tests. That means it is a non-treponemal test. So here VDRL, we know it is a non-treponemal test. So that is positive. But you have a negative reaction to specific treponemal tests. So TPPA or FTA ABS, these are the ones which are treponemal tests. Now whenever a non-treponemal test is positive but a specific treponemal test is negative, that means it is likely a biologically false positive and the woman, she does not have infection with treponema or she is negative for syphilis. Okay, so what is done is usually a non-treponemal test is done like RPR or VDRN. If that is negative or non-reactive, then the woman, she doesn't have syphilis or any infection. But if this VDRL or RPR is reactive, then you will do a confirmatory test with a treponemal test. So you can do an enzyme immunoassay or you can do a chemiluminescent enzyme immunoassay or you can do TPPA or you can do FTA ABS. Now, if any of the specific tests are non-reactive, that means of course there is no syphilis. But if these specific treponemal tests are reactive, that means there is infection or the woman has syphilis. Okay, another very commonly asked question is you have this 50-year-old woman, she has pelvic pain, she has been using a copper coil or she has a coil in situ for the last 8 years. Okay, when you examine her, you notice that she has a pelvic mass and she has undergone a laparoscopy for the chronic pelvic pain and the histological sample shows that there is presence of sulfur granules. So what is the most likely causative agent for her chronic pelvic pain or for the pelvic mass? So it could be Actinomyces israeli, Chlamydia trachomatis, Gardnerella vaginalis, Neisseria gonorrhoeae or Neisseria meningitidis. Remember, whenever you hear the word sulfur granules, it cannot be anything else other than Actinomyces israeli. Okay, so this organism normally it is a commensal of the colon, mouth or vagina and it is the commonest cause causing actinomyces. So the majority of cases they affect the cervicofacial area. Classically they present as painless facial lumps, but however sometimes you can get infection in the thoracic, abdominal or pelvic cavity and diagnosis is usually made from histological samples taken at surgery and the presence of sulfur granules is very characteristic of Actinomyces infection. Okay, many of us are doing IVF, so I think this question would be very easy for all of you. A 37-year-old woman has undergone 3 cycles of IVF. Each time a double transfer was done with a grade 1 embryo, but every time she has recurrent implantation failure. So which of the following immunological factors is responsible for this condition? NK cells, HLA-G, HLA-A, Langerhans cells, or uterine macrophages? The answer here is HLA-G. Okay. We know that recurrent implantation failure is one of the most common causes of unsuccessful pregnancy in women, those who are undergoing in vitro fertilization and embryo transfer. So, it is this human leukocyte antigen G that is implicated in recurrent implantation failure. Which of the following sexually transmitted disease is caused by Haemophilus ducreyi? So, chancre, chancroid, granuloma inguinal, condyloma acuminata, or molluscum contagiosum. So, we know it cannot be chancre because chancre is caused because of syphilis. It could be chancroid, it could be granuloma inguinal, condyloma acuminata, or molluscum contagiosum. Let us see what is the answer. So, Haemophilus ducreyi, it causes chancroid. Okay. So basically the illness, it starts as small shallow ulcers that are painful and multiple. The edges of these ulcers, they are irregular. There is localized lymphadenopathy, and this sore, it may persist for several months if untreated, and the glands can suppurate through the skin. You have to know the causative organism for the other sexually transmitted diseases. So syphilis, we know, is caused by Treponema pallidum. Chancroid, as we just learned, it is called by Haemophilus ducreyi. Donovanosis is caused by Camelobacterium granulomatis. Lymphogranuloma venereum, or LGV, is caused by Chlamydia trachomatis. Gonorrhea, the causative organism is Neisseria gonorrhoeae. And non-gonococcal, it could either be Chlamydia trachomatis, Ureaplasma urealyticum, or Trichomonas vaginalis. Okay. So these were some of the common questions that could be asked in microbiology and immunology. I hope you have found the video helpful, and I hope I could be of some help to you to clear this exam. Thank you so much for watching the video, and good luck to you in your exams, and I hope all of you rock the exams. Good luck once again, and thank you so much for watching. Goodbye, bye bye, take care.